If you've been seeing somebody for 3, 4, 5, 6 months and they're doing fairly well, but they're not completely better, it's because you're not treating the right thing and they've just naturally healed. And the things that you're doing might even be what are preventing them from getting better entirely, right? Like especially when people miss the spine.
Then that's also a place that you're gonna end up being stuck. Hey guys, welcome back to another episode on the Performance Rehab Authority podcast. I'm Doc Caitlin.
I'm Doc Raj.
And today we're gonna be talking about where most PTs get stuck.
There's a lot of places. There's a lot of places where PTs get stuck.
So I actually have a pretty good story about when I first got out of school. I think this was within my first year. And for the longest time, I dreaded knee evaluation, knee, shoulder, particularly knee, because that's supposed to be a really simple joint. It's a hinge joint, right? So there can only be so many things wrong. I would get a knee eval and I would start going through everything, and then I would let the patient pull me off track because they had this specific thing and they had this special thing going on with their knee. And so I would poke around, and when it didn't make sense with what I was originally thinking, which by the way, everybody had PFPS, or plica syndrome. You
diagnosed everybody with plica syndrome?
There were a few. There were a few runners I was like, I can feel this moves, it's tender, plica. I was like, great, how do I treat that?
I'm always curious how do people come up with, like, as the plica, like what tests have you done well, I guess you're saying you didn't really.
Yeah, well,
poked at it.
That's the thing is, when you're not certain, that's when you're supposed to use your special tests, right? And so I went through all of that. I wouldn't do like ligament testing if it wasn't indicated, but I went through like, why don't we test the joint mobility? Why don't we test the strength? And we did all these things. And then I would go through special tests for meniscus since it was on, the medial side or the lateral side. And then all of my special tests would be positive. I was like, what the fuck? Like, these are supposed to help. Yes. They said, when in doubt, special tests.
Yeah. That's why you guys should be using special tests to confirm diagnoses, like at the end after you have an algorithm that you follow to like, this is what I think it is, and like here's another test that can confirm it. Not using it of like, I don't know what's going on, let me special test, because special tests, they test multiple structures at the same time. Like they don't, there's no clarity. And most of them, if you look at the sensitivity and specificity, are garbage. Not all of them, but most of them. So you really have to be able to know what you're using the test for and what you can expect from that test. And if you're just going in there and testing special tests, like if I do a meniscus special test, like you're just cranking everything in the knee and moving it all around, and it's like,
and it's never gonna feel good. Nobody's gonna say that feels great, Roger.
Yeah, like you could, whatever, Hawkins Kennedy, right? Special test that. Everybody's like, oh, positive impingement. I know, because I did that to everybody. Like, you see this? Like, oh yeah, you've got impingement. You should come in 3 times a week. We're gonna do all of the tests.
Yeah, and so when you're going through the evaluation, this is where I would get stuck. So first, people would pull me off track because they had something special going on that would get me off of my plan to begin with. And then when I wasn't sure, I would start going down rabbit holes and I would just confuse myself.
What do you mean there's something special going on?
Like if they said, oh, well, it only hurts this way sometimes, or oh, it's here, or sometimes it's this other place.
Oh, but they're giving you a bunch of information that you don't actually need, like a whole bunch of extraneous information that then leads you to just losing your thought process.
Yeah. Oh, and 10 years ago, I fell right on my knee and I skinned it and it hurt for a few weeks, and I'm sure that's relevant to my current knee pain.
I sprained my ankle 10 years ago, and it's never been the same. I had a herniated disc like 25 years ago. That might have something to do with it. I think that's why. What? My great uncle once fell.
When things like that happen, it is our job to let our patients know it doesn't work like that.
Well, this is one thing where most PTs get stuck, is they let their patients pull them off track. Like, I wouldn't go just telling your patients like, yeah, none of that matters. Depending if you have like the rapport and their respect, then you can tell them that. Like, for example, I had a patient send me a message yesterday that he's been a very hot lumbar radiculopathy, and he went and got an MRI because he had it scheduled for forever. And I'm like, sometimes it's okay. Like, sometimes people need to go get it to like for their peace of mind, and it's like just better for them because it's driving them crazy. Like, if they get it, as long as you know that you can talk them off the ledge. So this guy had pain with literally everything. He went through 2 prednisone dose packs before I started seeing him. He was seeing somebody else, and nothing was getting better. And he was like, I'm on pain medication and I'm done. Like I need surgery. There's all this stuff. And then he came in well, it wasn't yesterday, it was the day before, I think, because he had his MRI after I saw him. So he came in either way and he was like, oh yeah, this is great. I'm like 1 out of 10, maybe a 2 sometimes, right? 'Cause a lot of times I don't have pain at all anymore. And that was before he got the MRI, right? So he went from being self-described 8 out of 10 all of the time, having to lay down at work like every 20 minutes or so, and just being in excruciating pain and miserable with sitting and driving and going to the gym, literally everything, to a 0 to 2 at worst. Then had an MRI, and then the doctor told him, you have a severely, these are the words he used, severely herniated disc. You need to be very careful with the way you're moving. Absolutely do 0 squats and 0 overhead presses. And I was like, yeah, dude, I could have told you that. Like, that's what we've been dealing with the entire time. Don't let the words severely herniated scare you, right? The squatting and the overhead pressing aren't bad. It's really the way that you're moving, which is the same thing we've been working on the entire time, that has been what's made you feel better. And I said, don't worry, we're gonna keep getting you moving and squatting and lifting. I got you, in text.
Well, and I think that's a perfect example, because when patients come in and they're freaked out, that's where they tend to pull us off track. Even if it's not during the evaluation, it's somebody that you've been seeing for a long time. You're like, oh yeah, this person's doing great. And then they come in and shock the world when they have this other thing going on that's really just the way that they're thinking about it. And again, it's our job to, just like Roger did with his patient, to let them know, like, hey, it doesn't have to be that way. That's not true, as far as having to modify all these other things because of this new information. It may be true about the imaging, yeah, but it doesn't have to dictate your life because you have this severely herniated disc.
It's like taking a picture of your car to the mechanic, right? Like, I wouldn't take my car to the mechanic. I wouldn't take a picture of my car to the mechanic and expect them to fix it. I would bring the car.
Yeah.
If you have a car that has no wheels on it, and you take a picture and you're like, hey, this thing doesn't drive. I'm like, that's why, dummy, there's no wheels on it. So they slap some wheels on it and they're like, all right, you're good to go. You get in and it still doesn't turn on. Yeah. And they never knew it didn't turn on because they never actually went in there and tested things. They just looked at a picture, and you can't treat off that. I told them, I was like, hey, listen, like at the end of all of this, when you have 0 pain, if they took another picture, they're still gonna see that herniation.
Yeah, exactly.
You're gonna see it later on too. He's like, oh, nobody told me that. I'm like, yeah, duh. They don't tell you those things.
Yeah.
But.
Well, I think another place that PTs get stuck, and maybe it's in the evaluation if they don't entirely know what's going on, but I think even later in the treatment plan, is they stop having intentionality with what they're prescribing. So my story about that is I just started doing what everybody else in the clinic was doing. There are times where more of one diagnosis comes into the clinic, right? And there were periods where we had so much plantar fasciitis there, it was infested.
Oh, you mean when things come in waves? That's
yeah,
what I call it.
yeah.
I was like, more than one diagnosis? Yeah, you got a whole bunch. I haven't seen an ankle patient in 6 months, now I've got 10 ankle patients on my caseload. Yeah.
So when someone with plantar fasciitis would come in, when I was working at this clinic and I was still, fresh out, I was trying to learn from all the other people who had been there for years. They had the seniority, they had the experience, and I was just trying to grow my experience. They were using isometrics, roll out foot on a ball, do towel scrunches, fissures. If you don't know what those are, that's like doing a little jellyfish motion with your foot.
You're just doing this, just in the air. It's like towel scrunches, but air scrunches.
Yeah, it's just working on active range of motion to get the foot intrinsics, and a lot of people cramp up in it because we don't use it very often. But it was the same bucket of exercises and a lot of different variations of the same muscle group too. And then when one of my other coworkers started doing great toe abduction as the big secret, this is why plantar fasciitis patients aren't getting better, it's because they lack active great toe abduction. And so I would sit there on the fucking floor trying to help active assist for 20 minutes moving my patient's big toe.
Meanwhile, none of the PTs in the clinic can actively AB duck their toe.
And guess who still didn't get better? And by the way, these were some of the actual active patients that were coming in to my clinic at that time, and I was doing them a major disservice. They were wasting their time coming in because I was just like, you have plantar fasciitis, here's our bucket, this is what we're doing, let's see what we've got today.
You guys put needles in the bottom of their feet?
Yeah, as a last resort. I would save that and be like, all right, now, we've done everything else, and I think it's time. This is the most painful dry needling thing.
Yeah, that's fucked up.
Yeah, I'm gonna put this in the bottom of your foot, but don't worry. In order to be qualified to do this, I have to first have somebody do it to me. And then patients look at you and they're like, what are you about to do? And I'm like, don't worry, it's fine. It's just not pleasant.
Like, putting needles in the bottom of the foot is fucking terrible because there's the nerve endings are so dense there, right? It's like you have the withdrawal reflex. If you step on something sharp, what happens? You get your foot off it really quick.
Yeah.
Now you're putting a needle in there and you're liable to get kicked in the face.
Yeah.
I think it's pretty typical, right? Like I did that when I was treating, and before I had a solid understanding of what was going on. Like, people would come in. For me, it was a lot of shoulder people. I was like super uncertain about the shoulder. Like, just totally overcomplicated the shoulder in my head. I'm like, there could be all these things. There's internal impingement and external, and like the rotator cuff and labrum and scapular dyskinesia. That was a combination of dyskinesia and dyskinesis. Dyskinesis, right? Like well, these things and the forced couples, and I just like totally overcomplicated it. And I was like, we're gonna do everything, and everybody just gets so many exercises that really they didn't have a purpose. Like, and I think it's okay. I think it's okay to give your people very similar exercises, right? Like right now in the clinic, I'm sure you've seen me. I've got several people right now. They're doing Kelso shrugs and Serrano presses, and they all have it for slightly different reasons to accomplish something else, right? Like,
and that's the thing, is the reason, the intentionality behind it. It's not just using the same bucket. It's pieces of exercises that were put in the same bucket.
It's not like oh, well, you're a shoulder person or you're a neck person, so I'm giving you these exercises. Like, there's actually a very specific reason that everybody has it, and it's different. It's different reasoning for each person, and we've used different progressions of things to kind of get there, and we're gonna go different ways from there. But right now, I've got a little group of people that this week they all I'm gonna say they all, but several people this week have started doing Kelso shrugs and Serrano presses because they're very applicable to their movement patterns and their impairments and what their goals are. But yeah, there's a very specific reason, and that gets people stuck all the time. Like, you can't progress things if you don't have a well thought out process of why you're even doing things in the first place, right? If you're just throwing a bunch of random shit at them, it's like, all right, so great toe abduction, the fissures, the towel scrunches, the dry needling, like, what are you progressing there? Like, all right, we're done with towel scrunches, what do you do next?
Yeah, well, I think that whole bucket was, we're still not out of pain. So something there that we were repeating week after week wasn't working because they were never getting out of pain. And so that's where the last resort of the dry needling came into. But I think you make a good point with the intentionality behind it. You also have to know what you're doing and be certain that that's the issue that your patient is dealing with, or else you're not going to be able to provide intentionality when you're prescribing exercises.
And it doesn't matter how many exercises you do for the foot. If it was plantar fasciitis, if you're not like looking at the calf and making sure that the ankle can go over the shin can go over the foot, so there's not an inappropriate break in the foot, because plantar fascia is a tension problem, not a compression problem. Aside from that, the number of people that we see that come in with the plantar fascia diagnosis, that it's actually the back. And they've seen 2, 3, 4, 7, 10, 12 different people. They've had like plantar fasciopathy surgeries where they cut out parts of their plantar fascia and do all kinds of crazy shit, and they still have the pain because it's a lumbar radic and nobody's fucking picked up on it. So it doesn't matter really what you're doing if you don't have that ability to thoroughly assess and make sure you're even treating the right area.
Yeah. If you look at it as though you have a hammer and everything's a nail, you're gonna keep doing that. I think a lot of people get stuck in just looking at the body part, especially when then that person has been to a specialist, like say with plantar fasciitis, they've been to a podiatrist who gave them orthotics, who told them all of these things about the procedures that they might have to do. You have to be able to take a step back and look at the full picture and not just hear their story and get tunnel vision.
That's key. Yeah. People will fuck you up, man. They will come in, they try to be so helpful. This was actually something, again, that happened yesterday with Sean that came in. He was telling me all of these things that he has going on. And actually, I was thinking about this podcast. And I was like, I talked to him and I was like, dude, these are the things, like, people come in. And I have a good relationship with him. I know him kind of personally, right? Like, so I was like, these are things that people come in and they tell their PTs, and then their PTs just like jump all over the place because he's got a bunch of stuff, right? He originally came in for his back, and then he also has like this elbow thing, right? And he has this Achilles thing, and he has this other thing, and he like gives me information about all of them, and I've got to like, all right, so thank you for telling me about all of that. We'll get to it. Let's focus on one thing right now so we can make good progress there, and then like start sprinkling in some of these other things. So what's the most important to you? And then every time he comes in, he's like, here's all the things. I was like, this is what happens, and then PTs don't get any results because they get so confused because you give so much information trying to be helpful. He's like, oh, I figured more is better. And I was like, for me, yes, right? Because I can parse through it. And I was like, and I appreciate you telling me these things. I was like, I'm just actively thinking about the teaching that I'm doing and how this specific scenario where you're trying to be as helpful as possible just throws PTs off. And he's like, yeah, I can totally see that. I didn't think about it that way.
There's so many ways our patients can pull us off track, whether it's their being a poor historian or giving us needless information, or like even other injuries that they've sustained or little aches or pains, especially as one thing starts to feel better. Roger likes to call that the danger zone, because then they don't start worrying about that major thing that they came in for, and then they start complaining about this other thing, and it's like, nope, we still gotta keep the focus on this thing as long as you're, breathing and able to function for the most part. We still need to focus on what you came in for, or else if everything's important, nothing's important.
Oh, that's a good point. If everything's important, nothing's important. I was just sitting here thinking, like, do I like to call it the danger zone? I was like, shit, I do like to call that the danger zone. Yeah. Because it's dangerous, right? People are like, I feel better, so let me stop being as careful, let me stop paying attention, let me start doing those other things. And it's like, nope, just because you're feeling better, that never equates to actually, like, everybody feels better before they're actually doing better. And that throws PTs off too, because they don't know how to actually assess to see how are they actually doing, not just how are they feeling. That's a big thing in the insurance world, right? Everything's like 0 to 10, what's your pain? Like, here's your outcome questionnaire. If your pain's down and like your function's up a little bit, like, cool, you're good, let's discharge you. But underlying all of that, they still actually have some pretty solid impairments and dysfunctions, but you just don't know how to assess them and how to have that objective progression, even when they've been feeling really good. Saying like, yeah, you feel really good, but look at all these things we still have to work on.
And I think that's a key word, is progression. Is just like with your intentionality, you have to know when to push the gas a little bit further. There were a lot of people that earlier on when I was just a PT or just became a PT, and people were doing all these chair exercises, we were trying to get them out of pain. A lot of these active people never even really got out of the chair, and I wasn't progressing them because I wasn't thinking about it, or I wasn't taking the time outside the session to prepare and know what I was going to do. And so the intentionality, the continuous updating to what's going on as they start to get better, that's where we lose a lot of steam, I think, is when we never get people out of the chair. We don't progress them enough. Then we only get them 80% better. And then when they actually go do the thing and start cranking it up in the gym or on the trail or on the mountain, their pain comes back.
Yeah, I think a lot of that too is because people just miss the spine, right? And then they get treated for months. And, if you were treating for somebody for 2-3 months and they're 80% better, just look at the tissue healing timeframes and the natural regression to the mean there, right? Like 2 or 3 months, people are probably just doing better because it's been 2 or 3 months. If you've been treating people for 4, 5, 6 months, right? Which is crazy to me, but you've been treating people for 4, 5, 6 months, unless it's something post-surgical, right? ACL repair, whatever, then that's very reasonable. You should be doing more than that. But if they're 80% better, you're missing something, right? And they're probably only that much better because it's been that long and they've healed naturally, and it honestly has nothing to do with what you've been doing for them. And that might be a hard pill to swallow for some of you guys, right? But it's the truth. If you've been seeing somebody for 3, 4, 5, 6 months and they're doing fairly well, but they're not completely better, it's because you're not treating the right thing and they've just naturally healed. And the things that you're doing might even be what are preventing them from getting better entirely, right? Like especially when people miss the spine. Plantar fasciitis, probably a lot of it goes from the back. Lots of knee pain, a lot of it comes from the back, right? Like shoulder pain comes from the neck. So, when things don't make sense, it doesn't make sense. If you're treating the knee and somebody comes in, you're telling me a story about like trying to assess a knee not being able to provoke the knee pain at all, right? So if you can't like make it make sense, like I did all my tests, tested all the ligaments and the muscles and the joint and the meniscus and like all this stuff and like the hamstring, like, none of it makes sense. It's not reproducing the pain. I don't know what's going on. If you just start treating the knee, what are you treating? If you can't make sense of it and you start treating the knee, what are you treating? What are you doing? You're just making shit up, right? So you're missing the boat. If it doesn't make sense, it doesn't make sense. And when it doesn't make sense, it's probably the spine. Period.
I think that's another place where people get stuck, is just missing the spine in general. I was talking to our strength coach, Matthias, a little bit ago, and we were talking about clients and how in the industry, what happens is people tend to get better when they go to PT, but they've also stopped doing the thing. And so then they are doing their exercises, they get discharged, it's been a few months, the PT is proud of themselves because they've gotten this person out of pain, and then the person starts running. And then, at first it's okay, they get up to maybe 10 miles, everything comes back. And a lot of the time it's attributed to, well, you stopped doing your PT exercises. And it's like, well, no, you went through a whole plan of care and you never actually progressed to the point of pushing the gas and doing the thing.
Yeah, you have to have them. Well, for clarity here, Matthias he's a PTA that also treats. He doesn't treat in our clinic. He's a strength coach for us, but he's a treating PTA. Yeah. So we have clinical discussions with him, and he's a better. I wish he had a DPT because I'd love to have him as a treating clinician here, but we just can't put a PTA in the mix, even though it's better than most people. Yeah, if you don't walk people back to doing the thing, then you don't know you've helped them. I used to think of a story of a guy I met at a local CrossFit gym, and he was like, "Oh, you're a PT." Like, I always have my shirt on. He's like, "Oh, I love PT. I went to PT. It was super helpful." And I was like, "Oh, what'd you go for?" And he was like, "Oh, I was having knee pain when I was squatting." I was like, "Oh, cool." He was like, "Yeah, it was great. I went there, right? Like I stopped squatting entirely. They had me do a bunch of exercises. My knees stopped hurting." I was like, "That's great. So you can squat now?" He goes, "No, it still hurts when I squat." I was like, "What?" And he was like, "Yeah." And I was like, "So they didn't have you squat?" He goes, "No, we went, we did like bodyweight squats and stuff, but like not like with a bar, like what what I do here with cleans and snatches, and like they didn't have the equipment." I was like, "So what you're telling me," and it blew my mind because he's like, "They helped me a lot." Maybe in his mind they helped because his knees started hurting all of the time. It's kind of like in retrospect what I think, and that it wasn't hurting all the time. My understanding was it started hurting when he was squatting, then sounds like it started hurting all the time, and then it went back to only hurting when he was squatting. I was like, "So they didn't really help you?" And he was like, "Yeah, they helped me a lot." I was like, "But you still have pain with squatting. Like that's the thing that brought you there. That's what you told me. You went there because you had pain with squatting. You stopped squatting and stopped hurting. You didn't need to go see a PT for that. What did they do to help? Nothing, right? Like we did a bunch of random exercises, but if he would have just stopped squatting and not gone to PT, there's a high likelihood that he would not have been in pain, right? It would have been the same result. Then he went back to the gym, back to CrossFit, back to squatting, and his knees hurting again with squatting. But he thinks that PT helped him because it didn't. Like there was a period where he stopped squatting, but they never actually made him squat. The problem didn't get solved. And if you're not helping your people actually get back to the thing that they need to do when you're in rehab, you can tell yourself that you're getting good outcomes all you want, but you haven't proved it and you haven't proved it to them. And there's a high likelihood they go back to doing their high level activities, running 10 miles, lifting heavy, whatever it is, run, jump, swimming competitively, and it starts hurting again.
I feel like most PTs are aware of this, that people think physical therapy is for grandma and grandpa, and that if you're an athlete and you're in pain, you can't, it's too bad. It's because you're active and you're just gonna have these aches and pains. The stigma is that physical therapy isn't that great. And so part of our job when we came out of network and created, a cash-based physical therapy setting where we can focus on performance and focus on, having a good clinical skill set and applying this to all of our patients, we have to get patients to value PT again.
Yeah, we can do a whole podcast on problems in the industry.
I was going to say overall, I think most places that PTs get stuck are, one, they let patients pull them off track in a variety of ways. They miss the spine.
Yeah, if it doesn't make sense, it doesn't make sense. And you have to make it make sense, right? If it doesn't make sense for the local body part, or doesn't make entirely sense for the local body part, you're probably missing something. It probably has to do with the spine.
Yeah. And then I think the last thing that we talked about with PTs getting stuck was intentionality. And if you don't understand the root of something that's going on, or your exercises or interventions don't have a reason for them, then that's also a place that you're going to end up being stuck.
Hey guys, and make sure that you if you're watching on YouTube, like, subscribe, all that good stuff, and click the link in the description below to sign up for a newsletter so you can stay up to date on what we have going on. And remember,
if you're unhappy or unfulfilled in your career or your life, no one's coming to save you. It is your responsibility to lead by example, to pursue excellence, to learn new skills.
welcome to the challenge of raising the bar and drive the change that you want to see.
We'll see you.